Welcome back to Childbirth Education here at HighPoint Health. My name is Amanda Parker and this is part 2. We're going to discuss labor and delivery. First, I want to highlight the cervix. The cervix is the opening to the womb or uterus. In order for us to have a baby, it needs to do two different things. The first is called effacement. Effacement has to do with how thin the cervix is. It starts out at about 2 inches long, but it needs to become as thin as a sheet of paper in order for the baby to pass through. In this figure on the left, that top cervix is 0% effaced, meaning it hasn't started the process yet. That middle cervix is 50% effaced, and the last cervix there is 100% effaced. Having a thinner cervix helps for it to open. Think of the cervix as a giant rubber band. You know how those really thick rubber bands are super difficult to open, but the thin rubber bands are much easier? Same kind of idea here. The cervix needs to dilate in order for us to have a baby. I really like this photo here. It's from a birth center in California, and you can see here it shows a cervix from 1 centimeter all the way up to 10 centimeters, and you can see how this corresponds to the newborn's head. So how does the cervix do these things? It needs to contract. The muscles of the uterus tighten and help push the baby down towards the cervix. That pressure of the baby's head helps for the cervix to thin and open. We like to keep track of two different things when it comes to contractions. We like to keep track of how long the contraction is, or the duration, and then for that we measure from the beginning of one contraction to the end of that contraction. You can see here that these contractions are about 30 seconds long, so this mom's probably in early labor. The next thing we want to keep track of is frequency. We like to see what the range is between contractions, and how we calculate that. We go from the first contraction, the start of that, to that next contraction start. And you can see here that these contractions are about 4.5 to 5 minutes apart. I want to talk about true labor versus false labor. And I'm not really a fan of the term false labor, mainly because I do feel that every contraction you have is doing something, even if that means it's just tightening the uterus. But for ease, I'm going to talk about true and false. True labor, the contractions occur at very regular intervals, and these contraction intervals shorten over time. So at the beginning of your labor, your contractions may be 15 minutes apart, but they are super regular. You can set a clock to them almost. And then over the course of the day, they may decrease to 10 minutes apart, 8 minutes apart, etc. In false labor, contractions occur at irregular intervals. So you may have a couple that are 15 minutes apart, but then your next one is 2 minutes later, and then it's a 5-minute spacing, and then it's back to 10. Everywhere. The contractions will be all over the place. Another key with the difference between true versus false labor is the intensity. In true labor, the intensity will increase over time. So the contraction you had just now is worse than the contraction you had 2 hours ago. In false labor, the intensity remains relatively unchanged throughout the course of the contractions. The key, though, is true labor is not relieved by water, by changing positions, getting up and moving around, and false labor, almost all the time, water and rest helps those go away. So when you call us and you say, hey, I'm having contractions, I'm not quite sure if this is the real deal, what we'll tell you is to drink a big bottle of water and rest. If the contractions persist, that may be true labor. If they kind of dwindle out and they kind of stop, that's probably false labor. At the end of the day, true labor is what dilates the cervix, and false labor does not dilate the cervix. Another way that your labor can start is rupture of membranes. Now, this is just saying breaking your water. It may be a lot of fluid and a big gush, or it may be very little and a slow stream or trickle. It's generally clear and it does look like water. It may happen before contractions even start, but more commonly, the rupture of membranes occurs sometime during the course of your labor. If your water breaks, you want to call your provider or go ahead and go up to the birthing center so you can be evaluated. Now, sometimes the provider may have to break your water. So let's say you're in labor and we need those contractions to get a little bit stronger. You remember from part 1, we talked about the powers of the contractions. This is one of the ways that we can influence the power of contractions, because when you take away that water buffer, the baby's head is able to sit directly on the cervix and help with that thinning and opening. When you get to the hospital, the first thing that will happen is we'll place you on the fetal monitor. You can see here that this is external fetal monitoring. This bottom belt here that's blue, it's keeping track of the baby's heartbeat. And you can see that on the top of this monitor piece, that section in blue is the baby's heartbeat. We like that it goes up and down. We like that it stays up during contractions. All of those signal a healthy, happy baby. That top belt is actually keeping track of the contraction pattern. So on this monitor piece, those little hills that you see on the monitor, those are your contractions. Now on an external monitor, we can't really see how intense the contraction is. So what will happen is the nurse or provider will feel on your belly a lot because that's an easier way to tell how strong a contraction is. Now there's also an option for internal monitoring, but that's a special circumstance and you may not even need that. Now, some people go into labor on their own and some people need an induction of labor. Now, there's two different categories. One is elective induction, and generally those are inductions for convenience. And then you have medically indicated induction. Essentially, these are inductions that need to occur for either the safety and health of the mom or the safety and health of the baby. One medication that we would use is called Pitocin. Pitocin is IV medication and it runs through your vein. We start Pitocin very low and then we go up slowly over time depending on your contraction pattern. Pitocin is used very sparingly, so you may not need a bunch to get your body kicked into things. Now, Pitocin can be used when your cervix is favorable, and by that I mean it's already started that thinning and opening process. Sometimes we have to do an induction of labor before the cervix is favorable, so for that we may need to use a different medication to prepare the cervix. These medications are called Cervidil or Misoprostol. One of these can be placed inside the vagina near the cervix, and it helps that softening process so that it can thin and open so that we can use Pitocin next. So we're in labor. It's early labor, and we know this because contractions are about 8 to 15 minutes apart, and they're pretty mild in intensity. We can still walk through them, we can still talk through them, but we know that they're there. The cervix is closed to about 3 centimeters, so you make a couple centimeters progress over this time. And if your water is intact, laboring at home for this portion can be very helpful. For one thing, you're more comfortable and relaxed at home, but for another, you have that freedom of movement, and that can help speed things along as we learned in part 1. So this can last either hours or days for first-time moms. And by days, I mean you may have a run of early labor contractions and then you'll have a several-hour break to where you're not really doing much, and then you'll pick up again and you'll think that this is it. It can do that over a couple of days. So we want to make sure that you are spending this time in comfort. So this is a great time to stay at home. Now, you may notice an increase in vaginal discharge. It may be very mucousy. Sometimes it can have blood streaked in it, and that's called bloody show. That next stage of labor is called active labor. This is getting to be the real deal. The cervix dilates from 4 centimeters to 7 centimeters. Contractions are occurring every 3 to 5 minutes, and each contraction is lasting about 45 seconds to a minute long. These are pretty intense contractions, and this time period can last either 4 to 10 hours. It's hard to say. Contractions are really hard to breathe or talk through. You're kind of having to really use your breathing exercises. You really need to lean on something as you help to get through them. Active labor is the perfect time to come to the hospital. So we always talk about the 5-1-1 rule. When your contractions are 5 minutes apart, each contraction lasting 1 minute, and it's been that way for longer than 1 hour, is a great time to go to the hospital. This ensures that you're in a nice active labor pattern and your labor should progress from there. So this last part of labor is the toughest. It's called transition. The cervix is dilating from 7 centimeters to 10 centimeters. Contractions are ranging from 2 to 3 minutes apart, and they last over a minute. As I said, most intense part of labor, it lasts anywhere from 30 minutes to 3 hours. Patterned breathing here is very helpful during the peak of the contraction. And by patterned breathing, I mean a couple short breaths and then a long breath, and then a couple short breaths and a long breath. This helps to get you into a pattern, 1, so that it can increase your oxygen and the baby's oxygen, but 2, this pattern helps you focus on something to take your mind away from the discomfort. So transition is this last part of labor. We need to get to that 10 centimeters so that we can meet our baby, because the next stage is pushing and delivery. Now, pushing can last from 1 contraction to 3 hours. The average pushing time for a first-time mom is around 2 hours. We'll set you up in a good position, we'll teach you all of the mechanics of pushing, and we'll only push during contractions. This helps to use your contraction power and your own power to get your baby down and out. In between contractions, you're resting, you're making sure that you're taking nice, big, deep breaths, because this helps oxygenate you and your baby. All of this will be worth it because next, it's time to meet your baby. Immediately after delivery, we place the baby on your belly. At that point, the nurses are rubbing with towels. They're also making sure that the baby's stimulated to cry. Your partner can cut the cord, and then we place the baby immediately on your skin. HighPoint Health believes in skin-to-skin contact after delivery. This is important for a multitude of reasons. For one, it promotes bonding for you and your baby, but more importantly, it actually helps the newborn regulate the temperature, regulate their breathing, and their heart rate. So the best spot for a baby right after delivery is against your chest. Now, there is one last part of labor and delivery, and that's delivery of the placenta or afterbirth. You can see in this figure that the placenta first separates from the uterus, it passes down through the cervix and out the vagina. The provider will generally take care of this. You may have to do 1 or 2 pushes, but most of the time moms aren't even focusing on this because they're so in love with their baby. Immediately after the delivery of the placenta, your provider will be rubbing pretty firmly on the top of your uterus. This helps to make sure that that uterus contracts downward as it should. We want this to happen so that extra bleeding doesn't occur. So there are some special circumstances. Most babies come out just fine with mom pushing with no issues. Sometimes we may have to use a special tool called a vacuum or special tools called forceps. Obviously, we would discuss these with you before we use them and make sure that you understood the process fully. If you have any questions about these, don't hesitate to ask your provider. So now that we talked about contractions, how are we going to get through it? Some people choose pain management options. One of those options is called Nubane. Nubane is a drug that goes through your IV. It can make you pretty sleepy and groggy, and therefore it can also make the baby sleepy and groggy, so we only like to use this in early labor. During that transition period and during pushing, this medication isn't appropriate because we want the baby to be nice and happy and active and awake for us at delivery. The second option is something called an epidural. An epidural is a form of anesthesia. You can see this mom is leaning over the side of bed and the nurse's anesthetist is behind her. Essentially what they do, they clean off the back, they encourage you to get in a good favorable position, they numb the area with a little bit of lidocaine. They go through that numb spot with a needle that passes through your bones and your spine into a special spot in your spinal column. It's called the epidural space. At that point, they're able to thread a thin catheter that goes through the needle and into spot in your back. At that point, they're able to pull out the needle and the catheter is taped to your skin. You're laid back and then the nurse anesthetist is able to give you a medication through that catheter. Our goal with an epidural is for you to still feel pressure, but hopefully your pain will be greatly reduced. One thing about the epidural though, after you have it, you are unable to get up out of bed. So you'll need to be continuously monitored for contractions in the baby's heartbeat. We'll also need to drain your bladder periodically of urine because you won't be able to get up and move around. In addition, the nurses will be getting you in random positions that help to facilitate the baby coming down and out because we've lost that help of gravity. Now, most of the time, epidurals go perfect and we don't have any issues. Sometimes an epidural can affect your blood pressure, so we check your blood pressure very often after you get an epidural. We like to keep track just to make sure that you and baby are doing perfect. Another option is natural labor and delivery. And I want to talk specifically for those moms who are absolutely positive they're getting an epidural first. You will still need to know some of these natural labor and delivery techniques because You may not have an epidural for your entire labor. Some of those contractions, especially at first, will be unmedicated, so you need to know some of these tools to help you get through that process smoothly. So, for everyone who's doing natural labor and delivery, I always suggest preparing yourself and your support person. You're already doing something by preparing yourself by just watching these videos, so great work there. However, you definitely want to read about natural childbirth, read about the techniques, read about the good positions that you can get in for natural labor. What are some things that people use to help them through natural labor? What are some breathing patterns and breathing techniques? For your support person, have them research, what can I do to help my partner in labor? How can I be a good support person? By educating yourself and the people around you, you're better able to handle labor and delivery and be more prepared for when something changes during your labor. The next thing that's important is avoiding elective inductions of labor. I'm speaking strictly to elective inductions. These are inductions for convenience and should be avoided if you're wanting to do a natural labor and delivery. A medical induction is a completely different thing, and there are actually people who do medical inductions and they labor and deliver just fine naturally. But it can make it a little bit more difficult because you're in the hospital for longer and you're starting that early labor process in the hospital. So definitely avoid elective induction of labor if you can. Also, you want to wait till the appropriate time to go to the hospital. Remember how I said that early labor part can last a couple of hours, sometimes a couple of days? You are far more likely to continue that labor naturally if you're doing it at home. You're more comfortable, you can get in better positions that are more favorable to you, and the process goes a lot smoother. So waiting until that 5-1-1 contraction pattern is a good time to come to the hospital. Now you want to discuss your plans with your provider and your nurses. So during a prenatal appointment, make sure to bring up your desire for natural delivery. This is so that everyone is on the same page when it comes time to deliver your baby. When you check into the hospital, make sure to let your nurses know that you're wanting a natural labor and delivery. That way, they can be as supportive as possible. All of our nurses at HighPoint Health are very experienced in natural labor and delivery, and they are full of tips and tricks to help you get through this. The next thing I want to highlight is breathing. Breathing is so important, and it sounds like it wouldn't be, and it sounds like it's something that's very intuitive, and yeah, I know how to breathe. But I'm telling you, practicing your breathing really does help. So each night, 15 minutes before bed, get into a comfortable position and relax. Really focus on taking nice, big, deep, easy breaths. Focus on the movement in and focus on the movement out. You want to make sure to pick a focal point, maybe on the wall, maybe just right in front of you. Focus on breathing that focal point in and then pushing it out. Getting into that habit and the routine of nice natural labor breathing techniques really does make a difference. That way, when it's time to have your baby, you're already familiar with getting in that relaxed state. So breathing cannot be overstated. In addition, you want to be open to suggestions. So during your labor, you're kind of in a zone and you may be very, very iffy about doing different things. Make sure that you're open to suggestions. We are happy to give you ideas on how we can increase the strength of the contractions, on how you can get into better spots and positions that may at the time be the last thing that you want to do, but it's really helpful to be open to suggestions. And this last piece, know that you can. Every woman can do natural labor and delivery. Women have been doing this for thousands of years. I want to focus on the fact that this labor is one day of your life. You will make it through it and know that you can. Come into the birthing center with confidence that you are going to have your natural labor and delivery, and that sets yourself up for the best success. So this is the end of part 2. In part 3, we're going to go over cesarean sections and postpartum care. So don't forget to come on back for that. Thank you.